I want to talk about the cholangiocarcinoma. This is really a rare tumor, and there's a huge progress being made in this disease and try to understand this disease and also develop treatment in this disease, very tough disease. And there's a huge amount of research opportunities still in this rare tumor. And so here are my disclosures. So I want to try to balance out how much oncology sort of trial data versus sort of understand the disease as a whole. And I hope I've made a good balance on this. So I will start with some background information, diagnosis, treatment consideration, ongoing management. I will try to incorporate some of the new data. So cholangiocarcinoma, this is considered as a rare tumor because the incidence is only 1.67 out of 100,000 people in the US, 8,000 new cases per year. And because of our fabulous liver transplant program, liver surgery program, we actually get a lot of patients. That's why we're able to do trials on this disease in collaboration with other players. So this average age of onset is 70. And so if you look at, there's variations in the incidence all over the world. The highest incidence occur in Southeast Thailand, 90 patients per 100,000. China, South Korea, Thailand are particularly affected due to presence of parasitic worm, liver fluke, that infect the liver and the bile duct, and which is not the risk factors in patients affect our patient here. So cholangiocarcinoma, even for this rare disease, it's usually we would, when we talk about it, we will talk about anatomic location. Intrahepatic cholangio, extrahepatic cholangio, and gallbladder cancer, because the biological behavior can be different. And also the incidence of driver mutations overlap and differs. It depends on the anatomic locations. So, and the 5-year relatively survival based on the SEER database, and this is a relatively recent article published 2017. So you can see the if advanced stage patients, the survival, 5-year survival is 2 to 3%. And if you look at the localized disease or regional disease, and the survival differs, depends on the anatomic location. And that has something to do with the tumor biology, the response to treatment, and management of complications from those disease. So gallbladder cancer in early stage patients tend to do a little better compared, the worst would be extrahepatic disease. So there's a lot of challenge we face to make a diagnosis and to treat those patients. Here are some. I just try to sort of paint the general picture. First, the presentation is very vague. A lot of patients present with very vague symptoms, and then which for different reasons, and eventually lead to most of the patients, 80% of patients, when they're diagnosed, they're unresectable. In the 20% of patients resectable after surgery, 2/3 of the patients recur. Half of the patients will recur in the first year. So you can see most patients eventually will need palliative systemic therapy or local regional therapy to control the disease and manage complications. This actually takes a team of doctors to manage this disease. So this is sort of a simple scheme of diagnosis, basic workup, blood test, imaging, and testing. So I always tell my fellows that you really need to have a good triple phase CT scan with the liver protocol to able to get detailed information. Even with that, a lot of cholangiocarcinoma may not show up on the scan. You can see the indent of the tumor on the bile duct and the vessels, but you cannot see the mass. Sometimes on the MRI, we're able to see the lesion. So it's a huge challenge to spot those disease. So because of this, so I want to just give you some numbers. Those are from different papers. So there's a retrospective analysis of sponsored by Cholangiocarcinoma Foundation survey, and on patients, a large group of patients from the first time they went to see a doctor with a vague abdominal symptoms, to the diagnosis, the average time is 22 months, a very prolonged delay. Of course, this is not, we don't see those patients when they first present with those symptoms. I mentioned earlier in early stage recurrence rate is very high. And so there's another study on 256 patients diagnosed with cancer of unknown primary. This is a study from Hopkins. When they did a sequence analysis, eventually they sort of defined those patients to have cholangiocarcinoma. So like 21% of those patients with carcinoma of unknown primary in that study are actually cholangiocarcinoma. So we see the incidence of cholangiocarcinoma goes up, and actually carcinoma of unknown primary, the incidence is decreasing because some of those patients get lumped now into cholangiocarcinoma. We talked about patients, most of those patients, because of complexity and diagnostic challenge, result in delay in treatment. 80% of patients will need palliative treatment. 5-year survival from the survey, the survival historic prognosis is very poor, 2 to 3%. So when we have a patient, we even suspect patient has this diagnosis, that's when we start to get the whole team involved. I will show the members of the team that how tightly we work together as a team. And first question is this patient has resectable disease? So for any liver resection, there's always multiple factors play sort of important to make that determination. One is the tumor load spread. Is there invasion around the bile duct tree, vascular invasion? There's any intrahepatic spreading that by lobar disease. Does patient have metastatic disease? The other very important thing is even liver can regenerate, but it's a small organ. So does patient have cirrhosis, portal hypertension? Does patient have liver hypertrophy? What's the functional tissue remain after resection? So all those sort of needs to come as a determining factor for resectability and overall condition comorbidities, technically possible. So then the whole team meet together and talk about the case and decide, well, this is potentially resectable. After resection, and it's important to discuss if patient need additional therapy, adjuvant chemo versus chemoradiation. So currently we have capecitabine, which is oral chemo, 6 months for most patients post-resection, but the benefit is modest. So we're trying to do combination immunotherapy trials in those patients to improve the outcome and to lower the risk of recurrence, and radiation. So any patients with lymph node spreading or positive margins, we need to consider chemoradiation. If they are not resectable upfront, can we downstage this patient and make them curable, especially in patients, young patients? So then the whole team get together and say, well, can we give patient chemo? Can we do local regional therapy with IR, radioembolization? Can we do radiation proton therapy, shrink the tumor, and eventually bridge patient to resection? If patient doesn't have enough functional, minimum functional tissue remain after resection, what strategy can we make the liver hypertrophy? So we work with interventional radiology to do portal vein embolization, ligate the portal vein to the tumor site, perfusing the tumor site, and try to make the non-tumor site hypertrophy. And we do Y90 radioembolization, also try to make the non-tumor site hypertrophy. Basically, how can we get this patient to resection? And the recurrence rate, and list here on the lower table, also shows the recurrent rate is very high in those patients. So now I think I want to present a study that published 2 years ago on socioeconomic disparities in this disease. So there's a very beautiful paper published 2020. What they're doing is they're looking at like patients who receive therapy. Do they receive therapy according to guideline? So then they look, you can see first we want to look at older patients or younger patients. So 42% of older patients do not get systemic therapy according to guideline. Usually, probably it's comorbidity. They may have poor liver or kidney function, cannot tolerate the chemo, will not be a candidate. For young patients, 18% of patients get treatment, not according to the guideline. But if you look at a different ethnic background, the patients with different ethnic background, Hispanic patients, 36% of patients do not get the treatment according to guideline. Black, 32%, white, 29%. So those treatment, so two messages. One is a lot of comorbidity may prevent patients from getting the standard of care. Second, the standard of care may not be as easy to receive. So key factors, usually when we have a patient's, what's the treatment goal? Extensiveness of disease, tumor status, initial diagnosis versus recurrent disease, what the patient's performance status are. Do they have comorbidities? We need to address all those comorbidities in order to make sure those patients are candidate for treatment. And important profile, do we have tissue for profile? And it is difficult to make a diagnosis because a lot of times we don't even get tissue to make the diagnosis. Now, to do profile right now with tissue, you need a core needle biopsy. A lot of times we may not have. I want to tell you how important to get tissue for profile for sequencing, next generation sequencing of those tumor. So this is the multidisciplinary team. And you can see it's a team of doctors that are involved in the diagnosis, treatment, and palliation. So patients, even they have advanced stage disease, and even they don't have any systemic therapy treatment option left, they can still not go without the whole team of doctor caring for them. So I think diagnosis, and it's pretty straightforward, GI, hepatology, IR, radiology, pathology, all play a very important role in making the diagnosis. Then the treatment, the surgeons, hepatology that provide transplant option, oncology, systemic therapy, intervention radiology for ablation, TACE-TEL, radiation oncology for radiation therapy. We all play a very active role in treating this disease. And palliations. So we have social worker, dietitian, palliative care service, in addition to all the members who are involved in treating this disease or involved in the care of this disease. So important things that how can we make people live longer is to treat the cancer-related complications that will have a great impact on patients' outcome. So obstructive symptoms like biliary obstruction, it is critical to get those biliary obstruction resolved because that will have a great impact on patient survival and also make them candidate for treatment. And pancreatic duct obstruction, then they can have pancreas insufficiency. They need to be treated so they can get enough nutrients. Gastric outlet obstruction, and that's also very important to address for nutrition, for comfort. So currently, systemic therapy, medical oncologist role, here are the options we have. The list is growing. So we have chemo, immunotherapy, precision oncology. So this is sort of the historic review on what's happening from 2007 to 2004, and all those approval of systemic therapy in cholangiocarcinoma, and some of agnostic approval. So approval not for specific tumor type, approval based on biomarker. And we also have the approval for specific cholangiocarcinoma for the disease. So you can see from, I can list a couple, 2017, all patients with microsatellite unstable mismatch repair deficiency tumor are approved for immunotherapy because those patients can respond to immune checkpoint inhibitor very well. And then we have, the next year, we have the high tumor mutation burden. But how do we find those patients? We need a tissue profile to find out the status of that in these patients. And then another agnostic approval is NTRK fusion. So we found, but it's a small portion of patients with cholangiocarcinoma. If there's an NTRK gene fusion, that's considered driving mutation. And the NTRK inhibitor works very well and really prolongs survival. And then other are more specific for cholangiocarcinoma, and very big target is FGFR fusion, FGFR2 fusion. And now we have 3 FDA-approved treatments. The FGFR mutation, so initially we did a study, basically enrolled patients with wild-type FGFR, FGFR mutation, and FGFR2 fusion. And patients with wild-type FGFR do not respond at all to the inhibitor because it's not a driving gene in cholangiocarcinoma. And the mutation, a portion of the patients will respond to the FGFR inhibitor. But if patient has FGFR amplification or fusion, those patients rely on their overexpressed FGFR to really proliferate. So now we have 3 FDA-approved treatments for cholangiocarcinoma with FGFR2 fusion. Then we had the immunotherapy, 2 immunotherapy approved in 2022 and 2023. Recently, we have a agnostic approval of it's a antibody drug conjugate targeting HER2. So this is called deruxtecan. And it's a antibody targeting HER2 attached to a payload of chemo molecule. So it brings this, I tell the patient, it carry the missile with the target to the tumor that makes has HER2 amplification. So currently we have a agnostic approval for any patients with HER2 overexpressed tumor. Cholangiocarcinoma is a tumor that a portion of the cholangiocarcinoma makes a lot of HER2. So we have another option. And other interesting target are the BRAF V600E mutation. We don't have any FDA approval yet, but we have very promising data. So now let's go over some of those options and the data that support this. So 2010, this is a global study that established cisplatin gemcitabine as the first-line treatment. And that at that time was comparison with gemcitabine. You can see the median survival 8 months to 11.7 months. The benefit is so it's like hazard ratio 0.7, but still the prognosis is quite poor. We've used GemCis as a frontline therapy for more than 10 years without any positive trials. We did many trials. A lot of those came back negative. Until now, we have 12 years later, we did a study called TOPAZ-1 study. So this study, so if any of the trainees rotate through oncology clinic, we're sort of passionate about running trials. So this is sort of an interesting story. The study started with the investigator-initiated trial in South Korea by Dr. Oh. They have a lot of cholangiocarcinoma in the hospital. So she proposed, let's try immunotherapy in this disease because there's a lot of preclinical data suggests this may be a good target, maybe good therapeutic agent to try. So he did like those phase 2 study, and the main cohort is durvalumab, which is is an antibody to PD-L1 immune checkpoint inhibitor, and that was tested in combination with GemCis with a very high response rate, very promising data that led to the FDA, led to this design of this global study, TOPAZ-1 study. And so this study is like a typical oncology study. Patients are randomized 1-to-1, durvalumab plus GemCis versus GemCis plus placebo. And so patients will get GemCis for 6 months with durvalumab, and it's a tough chemo. Patients stop the chemo, continue immunotherapy if they have tolerated treatment, has not had any disease progression. And so eligibility is if they are confirmed, tissue confirmed with measurable disease, good performance status, has not had any chemotherapy for advanced stage disease, they can have disease progression. The disease progression, they can have disease progression, but the progression has to be more than 6 months from surgery or more than 6 months from completion of adjuvant therapy. And so stratification factors. So when we do this global study, what we want to know is at the end, will the conclusion, are we going to have a very fair conclusion? So we always want to identify prognostic factors that may have impact on the outcome of those patients. So the prognostic factors, so the main prognostic factor we can think of is disease status. So patients with recurrent disease tend to do better. And then if they are initially diagnosed with advanced stage disease, for many reasons, some could be difference in biology. Some because patient recurrent disease, they have survived through the surgery. Those are usually robust patients. Third could be because now you don't have to deal with the biliary obstruction, because that's always a very difficult different comorbidities you have to deal with. The other is, we talked about primary tumor location. I've showed you the CO database survival. So you can see patients with different disease from different anatomic location can have different survival rate. So that's another primary tumor location we use to stratify the patients. So the primary objective is survival, because we want to know if we have a regimen that will have an impact on patient survival. So, so this is the original data presented at the 2 years, like 3 years ago now, at ASCO meeting. The study met its primary endpoint, and we were all so excited. I think Georgetown, we played a big role in the the study in the North America. We did a lot. We put a lot of patients on. We did a lot of. We sort of helped run the study, and looking at a lot of the important trial issues with the trials, and so the study met its primary endpoint with a hazard ratio of 0.8. But if you look at the median overall survival here, it's really small increment. And so we say, well, we're very happy the trial, finally we have a positive trial, but how much benefit, the question you ask is, how much true benefit patients do have? Will this benefit last? And who benefit most? Those are the questions when we look at this data, we're thinking about how to further analyze the data. So median survival, we are crazy about median survival, because in the past, when we try to compare 2 chemo regimen, that's the best way to compare 2 chemo regimen, which is better. Like if the one regimen has a much better median overall survival, and then it's a better regimen. But then when we start to test immunotherapy in cancer treatment, we realize the curve changes. So it has a very different survival curve as the chemotherapy curve, Kaplan-Meier curve. So is median survival a good way of reflecting the benefit? Can we really compare 2 regimens, one immune chemotherapy, one chemotherapy, with median overall survival as the endpoint? So over time, we realize the tail curve of the tail part of the Kaplan-Meier curve is very important, because a portion of patients will have prolonged survival for a long time that may not reflect, may not have a fair reflection by median overall survival. So now we start to do landmark analysis. So landmark analysis for TOPAZ-1 in the initial data presentation is at 2 years, a quarter of the patients are alive at 2 years, and 10% of patients with chemotherapy alone were alive. So then this study did meet the endpoint for PFS with a hazard ratio of 0.75. The response rate, there's increment, 19% to 27%, not a huge jump, but numerically it's better. Of course, the study is not designed to really tell the difference using of response rate. It's not designed, it doesn't have enough power to design to tell the difference. So now the first question we want to ask is, well, is the benefit lasting? Like if with longer follow-up, do we lose the benefit? And maybe the benefit is short last. So this so far is the longest follow-up on this kind of trial for cholangiocarcinoma. Now we published in May of this year the 3-year survival data. And so you can see, we're happy to see the hazard ratio actually improved. It holds on from 0.8 to 0.74, indicating that the benefit actually it's now observed seems more, or actually we're able to see more benefit when we have longer follow-up. And if you look at the landmark survival analysis, so to make the math easy, we did the OS rate ratio. So at 1 year is 1.15, at 2 years is 1.75. That means people receiving immunotherapy plus chemotherapy have a survival rate 1.75 of the patients receiving chemo alone. At 3 years, Now the survival rate increased to 2.21. So at 3 years, 15% of close to 15% of patients are alive receiving, if they have received the durvalumab plus gemcis versus gemcis alone. So this tells us, will sort of further validate what we've talked about earlier, like in the initial presentation. And so now talk about toxicities. So earlier I showed you health disparity on what patients sort of follow the guideline, the treatment follow the guideline. And I said sometimes it's because the treatment is not easy. And so if you look at so we are always provided very comprehensive table with all sorts of toxicities. I picked one slide and put a red arrow. And usually what I look at is I look at any treatment-related AEs. So that will give you sort of a general picture, like what kind of, how much, what's the percentage of patients gets treatment-related side effects. You can see it's very high, over 90%. But of course, a lot of those are grade 1, 2, like small side effects, not severe side effects. Now, if you look at any serious treatment-related adverse events, 15% versus 70.3%, still quite significant, but the number is much less. And also the other thing I look at is treatment-related deaths, 3% versus 4.1%. So it is not a walk in the park. The treatment can be quite toxic, needs to have a lot of close monitoring and management, especially for elderly patients with comorbidities. And the other message I want to tell you is numerically, you can see the number is not more if you with addition of the durvalumab treatment. So numerically, you don't see adding the immunotherapy has added more AEs numerically. But because it's an immunotherapy, we want to look at immune-mediated adverse events, 12% on the experimental arm, 4.7% on the placebo plus gemcis. First, when I look at this data, I say, how can it be? Patients receive placebo plus gemcis. But this is really, we are blinded to the results. So we have lumped some of the AEs to immune-mediated AEs without knowing that patient actually received placebo, did not receive any immunotherapy. But from this number, in general, the immune-mediated AEs, the number is pretty small. So as an immunotherapy, it is quite well tolerated. So the next year, we have another study called the Keynote 966 study, very similar design. And now they use an anti-PD-1 antibody, pembrolizumab, in combination with gemcis. The design is also different. So when we initially present the TOPAZ data, and you get a lot of criticism. People say, well, the curve started to separate at 6 months because you stopped the chemo. And maybe it's the study, it's the problem flawed with the study design. So this study is different, and it actually allow patient continue gemcitabine beyond 6 months. And so we were anxiously waiting for the data. The data was presented last year, and this is the data. So patients, it's, I would say, similar, but the hazard ratio is 0.87 or 0.83. It is a positive study. And if you look at the median overall survival, 12 months, I would say the data are quite similar. And this is a different immune checkpoint inhibitor. So we are told, like by my mentor, Dr. Marshall, many mentors, and says, well, you know, you never do cross-trial comparison, but we do it all the time because trying to put everything in perspective. So you can see this is the progress we've made. So ABC02, that's 2010, and gemcis versus gem, and we're able to, the median survival 11.7 months. TOPAZ and Keynote all around 12 months. So you can see the outcome is still pretty poor. Median survival about a year. And so if you look at the landmark analysis, at 1 year, a little more than 50%. At 2 years, about a quarter. And response rate, like less than 30%. So there are a lot of room for improvement. And safety, I think this durvalumab plus gemcis, the number seems to be a little lower, but of course we have to take this with a grain of salt. It's different study. And the Keynote study, this is the toxicity rate. The middle one was we had a lot of hope for the middle study, but eventually it came back negative. So the middle study also started with an investigator-initiated study from a fellow. And now she is a major player in the field and now works at the, Colorado. And she was a fellow at MD Anderson. So she designed this study to do triplet chemo. So gemcitabine, cisplatin, Abraxane. Initially, the phase 2 study had a response rate of 45% with the overall survival of 90 months. So we were very excited about the study. The study then was run as a phase 3 study called SWOG study. And the survival is still better, 14 months, but you can see the toxicity is a lot, it is a lot more toxic. So it did not really meet the primary endpoint. I think there's still utility of this combination in robust patients if you try to bridge the patients to resection. But currently it's not what we use because it's too toxic. And having said this, is you can see there's still a lot of room. So currently there are a lot of in immunotherapy world, and we're doing bispecific, so antibody that one arm target one immune checkpoint, the other target another immune checkpoint. We're doing combinations with the hope that can we hit more targets to bring the response rate higher, the survival better with less toxicities. So that's currently the trials that we have ongoing is focusing on that. So there's another big portion on cholangiocarcinoma is precision oncology. I call this cholangiocarcinoma, even it's a rare tumor, it's almost like lung cancer in the GI world. Lung cancer, it has a huge component of precision oncology. And you can, for HCC, the other sort of tumor in the liver, hepatocellular carcinoma, is different. The tumor can have a lot of mutation, but it's hard to find, it's hard to prove those are driving mutations. But for cholangiocarcinoma, it's a very interesting, a lot of these mutations are true driving mutations. If you target those, you get a great impact on these patients. So I want to show you sort of this from this paper showing, and so there's two, you can see there are a lot of mutations, up to 40% of cholangiocarcinoma carry mutations. We believe they're targetable, although we have not tested all of them. But there's some main ones that we either have FDA approval or very promising data. And you can see the prevalence is very different it depends on the primary tumor location. For example, intrahepatic cholangiocarcinoma, you have huge amount of patients with FGFR2 fusion. Right now we have 3 pills that targeting FGFR2 fusion. IDH1 mutation also high incidence. We have a drug for it. And the other mutations, the KRAS, there's a lot of development, but currently we don't have approval for cholangiocarcinoma yet. And for gallbladder cancer, what stands out is the HER2 amplification. So it is a huge, it's so like any drug that targeting HER2 may play a major role in gallbladder cancer. Extrahepatic cholangiocarcinoma, on the other hand, is you can see HER2 amplification. There's a lot of KRAS mutation. So obviously there is some difference in tumor biology. So it is important to really define optimal treatment options and combination based on the tumor profile. We did analysis with our patients that we've seen in the last 5 years at Lombardi, and even we're very aggressive trying to get profile. Half of the patients, we don't have profile information because we don't have the tissue. So now there are circulating biomarker, like liquid biopsy. And we use that a lot for lung cancer, but for cholangiocarcinoma, it has not worked the greatest. So there's still a lot of work to be done for that. Sorry, I think I... So this is some data on FGFR2 fusion. So I want to show you, remember for that TOPAZ study, the median survival is about 12 months. So you can see that currently we have 3 drugs FDA approved, and they're first generation, second generation, third generation, and ongoing. So for first generation, you can see the response rate, 23%, median survival 12 months. When we develop this irreversible inhibitors to FGFR, FGFR2, and then we're able to see the response rate goes up to 30%, 35%. The survival now goes up to 21 months. And then we have another, like the third generation FGFR inhibitor that they binds a different domain of the receptor, and that can overcome the resistance, because those kind of drug, the gene actually develop mutations on the binding side and result in resistance. And so those, and you can see the response rate is even higher with good survival over survival duration. So they are FDA approved and currently are being tested in the first-line setting. And we have another generation of FGFR2 inhibitors are being developed. There's a very promising data. So this is the one targeting IDH1 mutation. IDH1 mutation is very unique. It's found in cholangiocarcinoma and AML, and like leukemia. And the mutation, what we believe it works is it actually generates these oncometabolites that change the tumor microenvironment and affect the immune surveillance of the tumor. And that's what we think it works. But I think there's still a lot of research going on. And so this one, so there's a study have shown, you can see patients with IDH1 mutations. This is in a second-line setting. If they get placebo, their median survival is only 7 months. It's very aggressive tumor. And with the Resectability, which is IDH1 inhibitor, the median overall survival improved by close to 3 months. And it's still pretty short, but for this very aggressive disease, that's pretty good. And when you look at the hazard ratio, it's 0.79, is because there's a lot of crossover. But if you adjust the crossover, the benefit from crossover, the hazard ratio actually decreased to 0.49. So it is actually quite an effective drug in this disease. And the mutations occurred a quarter of the patients with intrahepatic cholangiocarcinoma, some in extrahepatic cholangiocarcinoma. So this is the HER2 data. So targeting HER2, and we talked about the prevalence depends on the primary anatomic location. So there are many, it's very active field. So we are doing combinations. We have different antibody targeting different domain of the HER2. And we also have bispecific antibody targeting different domain of the HER2 molecule. We also have antibody that with a link goes to a chemo, have a payload of chemo and bring the chemo to the tumor. And so it is quite, you can see those are very small studies, and the response rate can be as good as 36%. Interestingly, if you use antibody, you need a lot of molecule on the surface of the cells. If you use the antibody drug conjugate, then you don't need a high concentration of the receptor. You only need less receptors on the surface to be able to cause killing. So which showed on HER2 low expression tumor, you see some of the patients will respond to this strategy. So now I think if you go to an oncology meeting, you're going to see a lot of data on bispecifics. The benefit of bispecifics is, other than you combine two antibody, is you can really, in the local environment where the tumor cell is, you can hit both targets. So more effectively hit that target, or there's a lot of antibody drug conjugates, and that bring chemo and using the missile system and taking it to the tumor. And the other very exciting sort of area is cellular therapy, because HER2, there are a lot of CAR Ts. So basically we take patients' immune cells, and then we take the patient's immune cells and transfect the modified receptor that binds to HER2. So then you generate this very aggressive immune cells from the patient because of the ex vivo modification. You give it back to the patients. So those T cells, or we also have a monocyte like CAR monocyte trials. Basically, you try to get those immune cells go in to find the tumor, attack the tumor that way. So there's a huge development. Those probably in a few years, we're going to have a lot more data. So this is another, so this is a tyrosine kinase inhibitor targeting HER2 molecule in combination with antibody. And you can see some of the response rate is very good, it's 46%. So this is a bispecific antibody that target both domain, like different domains of a HER2. You can see the response rate is as good as 41%. So the issue with this kind of study is, even for Georgetown, we have a lot of patients. If you try to divide that into gallbladder cancer, 20%, the number becomes very small. So this always require international collaboration to run this kind of study to make an impact. So there's, I think I'm about to finish the talk. So now we're talking about the NCCN guideline. It's an ever-growing list of options. So patients with cholangiocarcinoma, I think we want to treat the comorbidities and we want to do profile, and then we want to try some of this treatment if we can. So summary, cholangiocarcinoma is best cared by a multidisciplinary team. Curative resection is an uncurative option for cholangiocarcinoma, but the risk of recurrence is high. There's a lot of improvement needs to be made to lower the risk. Chemotherapy is standard for advanced biliary tract cancer. Currently, the first-line treatment is an immune checkpoint inhibitor, durvalumab or pembrolizumab plus gemcitabine. And FOLFOX, other chemo can have shown survival benefit in a second-line setting. All patients receive systemic therapy should have a tumor profile, And I hope I've convinced you on that. Inhibitor targets FGFR2, IDH1, HER2, BRAF, V600E, which I have not shown you the data, show improved clinical outcome in patients with biliary tract cancer with corresponding genetic alterations. So future directions, we also touched upon that. Novel IO therapy, now we're working on LAG-3, TIGIT, there are many immune checkpoint inhibitors are being tested. Antibody drug conjugate, bispecific antibody, cellular therapy are being evaluated for cholangiocarcinoma. So we actually, Lombardi formed the cellular therapy group disease team about a year or two ago. Now we're actually having some of the solid tumor cellular therapy trials. Currently, GI related, we're trying to open a GPC3 study, like a CAR-T study against HCC in an international trial, phase 1 data. For that study actually showed a response rate of 75%. So we're trying to bring that to Lombardi to as an option. And we also have Claudin 18.2 CAR-T that's in the works, and that also have shown very promising results. So I think the next frontier is novel immunotherapy targets by specific antibody drug conjugate cellular therapy, and in some sort of combination, identify additional therapeutic targets. So Claudin 18.2, which is tight junction molecule, out of blue, and then scientists discovered this is a very important target. Now we have antibody, we have bispecifics, we have cellular therapy developed against this target. So finding an additional therapeutic target out of that 40% of targetable mutation is key. And the other thing is neoadjuvant therapy. Can we bridge more patients to resection, transplant to get them a better survival? Adjuvant therapy decrease the recurrence. We're going to have a study open that will test bispecific antibody plus chemo in the adjuvant setting. And then what's the goal? Cure more patients, preserve liver function, improve quality of life. We work closely with our IR radiation oncology team and try to also combine local regional therapy, which there are a lot of data on that, which it's not the focus of today's talk. So I have not, did not include those data in this discussion. So at Georgetown University, we actually have a very robust liver program, and we have many where tumor boards discuss those cases, get all the doctors involved in those discussions, like the little circles in one of the slides I showed you. And we also have monthly transplant meetings run by Dr. Rakani from liver transplant, basically trying to identify early stage patients who are candidate for transplant, which can bring a cure in some of the patients. We have a very robust active clinical trial portfolio, and that like at a different level of care in this disease, including education on patients, like bring like narrow the knowledge gap and health disparity on education about tumor profile. So we actually have a very active program, and I think a lot of you sit in the audience are probably part of that multidisciplinary team taking care of this disease. So now I'm open for questions.